So in our next few videos, we're going to talk about pathology. And so this video is going to be kind of a bridge from our previous physio talk now to pathology. So we're going to discuss a little bit of both. So we'll just recap some of the physio we talked about in our previous video, some general physio. What does your kidneys do? Let's draw it out. Here's your Bowman's capsule, your PCT, your loop of Henle, your distal convoluted tubule, and your collecting duct, right? And we said grossly the three main functions was that one, blood goes to your kidneys. So our blood supply. Stuff gets filtered through. Their nephron works as magic, so I just write renal function. Just general renal function. And then lastly, after it's secreted the things that it doesn't want and reabsorbed the things that it does want, you pee it out. Clearance, right? Clearance. That's like what your kidneys do in a nutshell. And you can imagine if anything happens to any of these three steps, your kidneys can stop working. Something can happen to your kidneys. And what do we say what happens when your kidneys stop working? You get buildup of byproducts, you get all that nitrogenous waste building up, all that creatinine building up. So if you disrupt any of these three steps, you get renal failure. Yeah? Acute renal failure. Acute renal failure. And that will be the topic of today. And we said when your kidneys stop working, you get a buildup of byproducts and nitrogenous waste. Sometimes we call acute renal failure azotemia. A-Z-O-T means nitrogen, emia means in your blood. So you get nitrogenous waste in your blood if you disrupt these three steps. Now there's some terminology that you should know. If you directly disrupt your renal function, if something happens to your kidneys, like I said, in our next 6 videos, we're going to talk about all about renal pathology. Yeah, we're going to talk about a ton of stuff. And all of those things can harm your kidneys and cause acute renal failure. When it harms your kidneys, we call this intrinsic. How about clearance? If there's like a stone or obstruction here, this is after your kidneys have done its job. Your kidneys have done its job and then it's trying to pee. It's trying to clear things out. You're trying to pee, but there's some sort of obstruction. There's something blocking the clearance. This is called postrenal because it's after the kidneys. And then opposite that is what happens if something occurs before your kidneys? Before your kidneys can do its job. What happens if in your vessels you have a block and you can't supply blood to your kidneys? You don't even reach your kidneys yet. You have a problem even reaching your kidneys. Problem with your blood supply. We call that prerenal. Prerenal. All right, so just some terminology you should know. And if you disrupt any of these three steps, you get acute renal failure. Now, we like to break things down just to simplify things, but your body doesn't, separate things so clearly. Everything works together. And so pathologies often mix these together. I mean, if you have a stone right here, a postrenal problem, eventually that fluid will build up and destroy your kidneys. Now it becomes a intrinsic renal problem. All right, so just know that they're not so clearly separated and defined, but for the sake of this video and for the sake of simplicity, we're going to kind of break things down into these three categories. All right, let's talk about what can cause disruptions to these three categories. Prerenal, something's disrupting the blood supply. There's 100 things that I'm not even going to go into. You can have ischemia, you can have shock, you can have stenosis, you can have NSAIDs, you can have anything. Yeah, and this disrupts the blood supply. Shouldn't be hard to figure out in the question stem. Yeah, disrupts the blood supply. So, all right, disrupts blood supply. How about clearance, postrenal? Something's blocking here. Again, 100 things that we don't need to get into. Things like stones, benign prostate hyperplasia, things like cancer invasion. Shouldn't be hard to pick up in a question stem. Someone's having trouble urinating, peeing, getting things out. It's post-renal. Yeah, it's not a problem. Now, the one that can be kind of funky is intrinsic. Something wrong with your kidneys. And we're going to talk about a ton of pathology in our future videos that all can cause this. But there are about 4 conditions that kind of don't fit into the categories of those videos. And so we're going to talk about them now. Yeah, kind of wet your whistle, kind of bridge you from physiology onto pathology. So we're going to talk about some pathology. We're going to talk about 4 main ones. One of them is called acute tubular necrosis. What a fitting name. Something's causing your nephrons, your tubes, to die. Something's causing them to die. This could be anything that's nephrotoxic, aka 12.5 drugs that are nephrotoxic. Acetaminophen, you can have radio contrast agents, so if you need to do like some sort of imaging and you have radio contrast agents, those are the agents. You can have crush injuries, cancer. We said that when cells die, they release a ton of stuff, and that can damage your kidneys. So I'll just write cell injury. You can have ischemic causes. Wait a minute, did you say ischemia was prerenal? Mess with the blood supply? You're absolutely right. But I also said that things aren't so clearly defined. If you have enough ischemia, your kidneys are going to get shot. I mean, that's a no-brainer. So ischemia. They like to ask you where in particular does your renal get affected by ischemia the most? Grossly, let's just draw your kidney grossly. You have your cortex, right? Your outside layer. Then you have your medulla, which is your inside. And in your medulla, you have all your nephrons that make these pyramids, called renal pyramids. And they end in these papilla, drain into your calyces and your renal pelvis and now your ureter, right? Well, in the deeper medulla, that's the most susceptible to ischemia because blood supply goes from out to in. All right, so it's furthest from the blood supply, so I write medulla. So that's looking at the kidneys grossly. How about looking at the kidneys microscopically? How about your nephron? What's the most susceptible? It'd be your PCT and your ascending limb. Why is that? Because your PCT is a workhorse, so it needs a lot of blood supply and energy to supply all that. And then your ascending limb is another workhorse. It has that giant sodium potassium chloride pump. Okay, so PCT and thick ascending. With probably your PCT being the most important because again, it's the workhorse. So ischemia can affect your kidneys. And when they affect your kidneys, your tubes will die. That's the tubular necrosis part. And when they die, they plug up your kidneys. They plug up your kidneys. Yeah. And some of those dead tubes can go out into your urine. You'll actually be able to see the cast or kind of gravestone. It looks muddy brown cast. Because they plug up your kidneys, your GFR will decrease. And they like you to know the stages of injury. So the first stage is the inciting injury. Something happened, whether it's nephrotoxic drugs, whether it's ischemia, something happens, that's the first stage. Then afterwards, your tubes will die and plug up your kidneys. We call this the oliguric phase. Sometimes called the maintenance phase. And you can't pee. Yeah, all these plugs are plugging up your kidneys and you can't pee. So waste product builds up. I mean, that's the name of the game, right? Waste product builds up and builds up. Potassium builds up. Uric acid builds up. All these things build up. You're in a lot of danger at this stage. I would say it's the most dangerous to put a star over here. Because anytime, when you have potassium buildup, you can get arrhythmias. So anytime you have a bunch of these waste products building up, you're in a dangerous phase. But, here's the hoping. Your kidneys recover. These plugs get removed and they get filtered out. Your kidneys recover. This is called the recovery stage. Now you're not out of the woods just yet. Once your body recovers and removes these little dead tubules, these dead plugs, then now your body says, oh, I got all this waste product. I can finally let it go, relieve it. Shout out to Frozen. And you basically pee all of that out. And you have polyuria. Now you're just peeing out all that stuff like a racehorse, and you can get hypokalemic. So what happens if you get hypokalemia? You can have arrhythmias. Anytime you get any kalemia, you can have arrhythmias. So you're not out of the woods just yet. But after you've recovered, after you've been stabilized, then you can finally relax, okay? So that's acute tubular necrosis, from the causes to the phases to what you see: muddy brown cast, decreased GFR. All right, so that's one pathology thing we want to talk about today. Some other things that can harm your kidneys and cause intrinsic kidney damage. You can have drug-induced nephritis. Drug-induced. What do you think this is? This is when you take a drug, you have a bad reaction and it harms your kidneys. Okay? Any drugs can do it, but what you'll see is a few days or a few weeks after you take the drug, you start to develop a fever. You start to develop a rash. And if you check the urine, you'll see eosinophils. What do you want them to spell out for you? Eosinophils are so important in allergic reactions. And if you see it in your urine, then you know you're having some sort of allergic reaction that's affecting your kidneys, all right? So it should be dead simple. If you don't pick it up on the history, you should pick it up on the eosinophils in the urine. All right, so the history, we'll talk about a person that took a drug and then, and then afterwards, they developed this fever, this rash, this eosinophilia in their blood, eosinophiliuria in your urine. So very, very easy to pick up. What do? Stop the drug. Okay. All right, next is renal papillary necrosis. What are your renal papillas again? We said these are these small parts that finally drain into your calyces, drain everything out. What's important about these is that they are kind of the furthest away from your blood supply. They're the deepest in your medulla, and so they are susceptible to ischemia. So sickle cell can do this because sickling of your blood supply can occlude vessels. That's kind of the pathophys of a lot of sickle cell pathology. So sickle cell, diabetes. I'm going to talk about how diabetes affects your kidneys in a moment, but diabetes is one of them. NSAIDs, what do NSAIDs do that affect your kidneys? Don't they constrict your afferent? Constrict your afferent, causes ischemia, causes that renal papillary necrosis. And when these renal papilla die, they will slough off and go into your calyces, out your ureter, into your urine. Yeah, they're right there. I mean, they're like literally next door to your ureters, so you can just pee out. You will literally pee out your renal papilla. And you will see it because it causes gross hematuria. This isn't dark urine. This isn't your urine's a little bit red. This is gross hematuria. You're peeing bright red blood out. That's renal papillary necrosis. Gross hematuria. You gotta have that anytime you have a differential for someone peeing bright red blood. Last but not least, something called diffuse cortical necrosis. This is necrosis in your cortex due to ischemia. And you're thinking, wait, ischemia in your cortex, that's the closest to your blood supply. Well, how could that get ischemic? How could that get ischemic? This is in severe ischemia. If someone has diffuse cortical necrosis, they're basically telling you the patient has severe ischemia without actually telling you. So you see this in obstetric emergencies where the poor lady's losing like liters of blood per minute. You see it in shock. You see it in DIC where you just get severely hypoperfused quickly. So I just write severe hypoperfusion. Especially obstetric emergencies. So if they show you a picture of a kidney and the cortex is just white as a ghost, no blood supply, absolutely damaged, that's cortical necrosis, and you know that that poor patient had some severe acute loss of blood. Okay, and that actually does it for all the pathology I want to talk about today. Now, some physio that I want to talk about. Like we said, they like to complicate physio with things like charts, things like graphs. Here, they're going to like to try and complicate physio with some lab findings. What are some lab findings you'll see in acute renal failure? Well, what happens to your body in acute renal failure? You get a buildup of byproducts. You get a buildup of nitrogenous waste. You get a buildup of creatinine. Yeah? And in acute renal failure, when your kidneys aren't working, one of the first functions that goes is your kidney's ability to reabsorb sodium and concentrate urine. Yeah? Your kidneys aren't working, so they can't reabsorb sodium. All those pumps that we talked about, those ENaC pumps, the NaH pumps, all those things that reabsorb sodium, you can't do that if your kidneys are shot. So you get azotemia and you can't concentrate urine. Concentrate urine, reabsorb salt. That goes out the window, all right? So all the lab findings have to do with these two concepts. We'll talk about azotemia first. When we said that whenever your kidneys loses function, you get a buildup of byproducts. One of them was creatinine. Creatinine doesn't get filtered through, so you get a buildup of creatinine. We also say you get a buildup of nitrogenous waste. Sometimes we call it BUN, or blood urea nitrogen. Basically the urea and the nitrogen that's found in your blood. Now these two are a little bit different. We said that creatinine, any creatinine that goes to your glomerulus gets filtered through. Yeah, and you pee it out. Any BUN that gets here can get filtered out. And also some gets reabsorbed. All right. So you can bring some back into your body, usually at a ratio of about 20 to 1. All right, we can't really bring creatinine back into our body. In fact, that's why we like creatinine so much, because we can't bring it back to our body. So it's a ratio of 20 to 1. Normally, all right, normally. So that's the first part. How about the second part? What's the lab findings that tell us that your body is no longer concentrating urine, that is no longer able to reabsorb sodium? How about we just look at urine osmolarity? Urine osmolarity. If we're able to suck up sodium, which causes water to follow, then our urine will be very concentrated. That's what we're trying to do, make it really concentrated. So urine osmolarity would be high. So over 350 is normal. However, if your kidneys are damaged and you can't concentrate urine, you can't reabsorb salt, then you'll pee out salt, and with it water will follow. And so your urine will be nice and watery, nice and dilute. And so if it's under 350 osmolarity, then you know it's not normal. Now, osmolarity is a general term. It doesn't just mean sodium. You can have any sort of electrolytes can change your osmolarity. So if we want to look at just sodium, then we can look at, you guessed it, urine sodium. And like we said, if your kidneys are working, you're reabsorbing that sodium. So normally, it's less than 20. But if your kidneys aren't working, you aren't reabsorbing that sodium, then it's more than 40. You'll find a ton of sodium in the urine, so all right, not normal. And if you really want to beat this to death, another lab finding that they like to throw in is FeNA. The percentage of sodium that you're excreting. Normally, we want to reabsorb it, and so we should only excrete less than 1%. So this is right, this is normal. If your kidneys aren't working, we aren't reabsorbing sodium, then you will excrete more than 1%, so more than, all right, 2%. They're not normal. All right, so many different ways they can put it, many different ways they can try and confuse you, but as long as you know that your kidney's main function is to concentrate urine, reabsorb sodium and water, concentrate that urine, then it should be all right. So let's just look at this one by one. Let's look at prerenal damage. If we're looking at it in isolation, then that means your kidneys are still working just fine, nothing's wrong with your kidneys, but something's happening to the vessels that come before your kidneys, prerenal. There's like a block or there's ischemia, all right? So in isolation, prerenal doesn't have a problem with your kidneys. All right, so urine osmolarity will be normal, over 350. Urine osmol. Urine sodium is gonna be normal, less than 20. Fe sodium, gonna be normal, less than 1%. Now BUN creatinine is a little bit more difficult. BUN creatinine, we said that any creatinine that goes through the glomerulus will go through and get excreted. We said any BUN that goes through can get excreted as well as get reabsorbed. And your body will try and reabsorb a ton of it. Why is that? Well, it senses the ischemia. It senses that drop in blood pressure. And so it tries to reabsorb as much solutes and stuff as possible to try and raise back up your blood volume. So it will try and reabsorb BUN. What do you think that does to your ratio? You get an increased ratio over 20 to 1. All right, that's prerenal. Let's move on down to intrinsic. What are the lab findings for intrinsic? All right, intrinsic. Are your kidneys working in intrinsic? If we're looking at it in isolation, are your kidneys working? No, by definition they aren't. So by definition they can't concentrate urine, they can't reabsorb sodium. They're shot. So urine osmolarity will be not normal, under 350. Urine sodium, not normal, can't concentrate urine, over 40. Fe sodium, not normal, over 2%. No problems there. Well, how about BUN and creatinine? BUN creatinine. The ratio stays the same. Why is that? Well, because your kidneys aren't working. It couldn't make changes to your BUN creatinine if it wanted to. Yeah, basically, nothing's going through, so the ratio stays the same. That is intrinsic. Let's talk about clearance, postrenal. Postrenal is probably the most complicated. It's very hard to look at it in isolation. So it's variable. All right, so BUN creatinine is variable. All right, variable. And in acute problems, if you have a stone here acutely, you won't be able to clear things, but your kidneys are still fine. So if your kidneys are still fine, then you have all the signs of a good kidney. But eventually, as time goes on, as fluid builds up, then it'll destroy your kidneys and you'll have signs of poor functioning kidneys. So all right, variable. I'd be hard pressed to have them basically ask the question on postrenal lab findings, again, because it's so variable. These two, on the other hand, are fair game. All right, so you gotta know these well. So hopefully that kind of clarifies some things. That does it for this video. Hope you enjoyed. See you next time.